Imagine a scenario for a second. It's, I don't know, 2 in the morning on a Tuesday, you're in the ER, or maybe you're just at home, you're a parent, and you're looking at your teenage son. He's maybe 14. And he's walking funny, sort of hunched over, protecting himself. He's pale, bit of sweat on his forehead. Maybe he's thrown up once. But he's a teenager, right? So he's embarrassed. He's trying to downplay it. He's saying, it's just a stomach ache, or, I think I pulled a muscle at soccer.
That is the classic clinical trap. It is so easy to just dismiss that, to say, oh, it's probably gastroenteritis, a stomach bug, or maybe, a simple UTI, but the clock is already ticking.
And it's a really fast clock, because if you miss the real diagnosis, within 6 hours, just 6 hours, that young man could lose an organ. He could be facing fertility issues for the rest of his life, and a pretty significant psychological blow, too.
That is the absolute high-stakes reality of the anatomy we're going to get into today. It's an area of the body where pathology moves incredibly fast and where ignorance is definitely not bliss.
Welcome to the Deep Dive. Today, we are tackling what I like to think of as the check engine light of male health. We're diving deep into Chapter 86 of Baily and Love's Short Practice of Surgery. This is the 28th edition. The chapter is titled simply, The Testis and Scrotum.
It is a foundational test.
Probably.
Absolutely. And I think it's important to start with a really clear disclaimer right up front. What we're doing here today is an interpretation. We're trying to create a revision guide, a kind of mental framework to help these concepts stick in your brain. This is not a replacement for the textbook.
Right. We want you to listen to this, get the concepts locked down, and then seriously, go open the book. You need to see the diagrams. You have to study the staging tables for the tumors. We're here to give you the story, the narrative, and hopefully some memory anchors.
Think of it as the roadmap before you get in and drive the car. And we're going to cover a lot of ground today.
So here's that roadmap. We're going to start chronologically with the case of the missing testis, what the book calls maldescent. Then we're going to move to that absolute disaster scenario we just hinted at, the bell clapper deformity or, testicular torsion. From there, we'll get into the plumbing, the lumps, bumps, fluid collections. We'll break down infections, tackle the scary topic of tumors and the critical don't touch rules there. And then finally, some of the really nasty stuff like gangrene and trauma.
It sounds like a laundry list, but it all follows the anatomy and the embryology, really. If you understand where the organ comes from, it makes sense what can go wrong with it.
So let's start exactly there, the journey, because the testes don't start in the scrotum, do they? They have a commute.
A very long commute. Embryologically, the testes develop way up high in the abdomen, right next to the kidneys, which, makes sense later when we talk about their blood supply and where the cancer spreads. But they have to make this long journey from that high abdominal position down the back wall of the abdomen, through the inguinal canal, and finally settle into the scrotum.
And the first major problem in Chapter 86 is when that road trip goes wrong. Incomplete descent or cryptorchidism.
Exactly. So cryptorchidism is essentially the car stalling on the highway. The testes is on the right path, but it just stops short. Usually it gets stuck in the inguinal canal or maybe right at the neck of the scrotum.
Okay, so that's different from an ectopic testis. The text makes a clear distinction there.
Yes, it does, and it really matters for how you find it and treat it. An ectopic testis isn't just stalled. It took a completely wrong exit. It came down the inguinal canal, but instead of turning into the scrotum where it belongs, it just wandered off. It could end up in the femoral triangle or the perineum or even at the root of the penis.
So one is stuck on the route. The other is completely lost. How common is this? I feel like you hear about this in pediatric checkups all the time.
It's surprisingly common, especially in premature babies. About 30% of preterm boys will have an undescended testes, really because they just haven't had enough time in utero for the journey to finish.
Okay, and in full-term infants?
It's about 3%.
Yeah.
But here is the crucial statistic from Baily and Love that really drives the management.
Yeah.
Usually, if they're going to come down on their own, they do it in the first 3 months of life.
So there's a window of opportunity, but it's a short one.
A very small window. By the time that child is 3 months old, if the testes isn't down in the scrotum, it is very, very unlikely to descend on its own. The incidence settles out at around 1% by the time they're a year old. So that old advice of, oh, just wait and see until they start school, that's completely outdated and dangerous.
Okay, before we get to the fix, I want to talk about the retractile testis. This feels like a classic trap for a medical student or even just a worried parent. How do we tell the difference between a testis that's truly undescended and one that's just shy?
Shy is the perfect word for it. This is all about the cremasteric reflex. the cremus muster muscle. It's this little muscle that wraps around the cord in the testes, and in children, this reflex is hyperactive.
Right.
So if the room is cold, if your hands are cold, if the child is anxious or gets tickled, that muscle contracts and just yanks the testes up into the groin like an elevator.
So you could examine a totally normal boy in a cold clinic room and misdiagnose him with clitorchidism.
You absolutely could, and that leads to a lot of unnecessary referrals and a ton of parental anxiety. Baily and Love gives us a really clear clinical protocol here. You can't examine these kids standing up in some drafty hallway. You need a boy relaxed, in a warm room, lying down supine.
And what are you actually looking for physically that differentiates them?
Well, you look at the scrotum itself. In a true undescended case, that side of the scrotum is often underdeveloped. It looks empty, it looks flat and small.
Ah, okay.
Whereas in a retractile case, the scrotum is well developed because the testis does live there most of the time. Also, with a retractile testis, you can gently, milk it down from the groin into the scrotum. And this is the key. If you let go, it stays there, at least for a bit.
Right.
A true undescended testis either won't come down at all, or it just snaps right back up like it's on a rubber band because the cord is physically too short.
Okay, let's talk about the why. Why do we intervene? If a testis is stuck up in the groin, why not just leave it there? Is this just a cosmetic issue?
No, definitely not cosmetic. There are 3 major reasons we operate: fertility, cancer, and complications like torsion or a hernia. Let's start with fertility.
Yeah.
You have to remember, the scrotum is basically a climate-controlled unit. It's designed to keep the testes about 2 to 3 degrees cooler than core body temperature.
And that's essential for making sperm.
It's absolutely vital. If a testis is stuck in the warm inguinal canal, or worse, inside the abdomen, it's being cooked. The heat damages the Sertoli cells and the Leydig cells. We can see microscopic degenerative changes happening as early as 1 to 2 years of age.
Wow, that early.
That early. And if you have bilateral undescended testes, so both sides are stuck, and you don't fix it, the risk of azoospermia, which is having a 0 sperm count, is almost guaranteed.
So you're literally in a race against that heat damage? What about the cancer risks?
This is the one that really scares parents, and rightly so. An undescended testes has a risk of developing cancer that's significantly higher than the general population. The most common type is a seminoma.
So does bringing it down the surgery, does that eliminate the cancer risk?
This is a critical point, a really important nuance. And the answer is no, it does not. The thought is that the genetic or developmental damage that predisposes it to cancer is likely already done. However, just think about the logistics. If a testis is inside the abdomen, you can't feel it. You can't examine it. A tumor could grow to the size of a grapefruit before anyone notices.
Right.
By performing an orchidopexy, which is the surgery to bring it down into the scrotum, you make it palpable. You allow for self-examination later in life. So you aren't really preventing the cancer, but you are enabling an early diagnosis, and that's what saves lives.
That's a huge distinction. You're just moving it to a place where you can actually monitor it. Okay, so let's talk about the solution. Orchidopexy. When are we doing this?
The timing has gotten younger and younger over the years. The current consensus is to operate somewhere between 6 and 18 months of age. You wait past 3 months to see if it'll drop on its own, but you really want it done before 18 months to try and stop that heat damage we were talking about.
Now, the standard surgery sounds, straightforward. Find it, bring it down, stitch it in place. But what if you can't feel it at all? The so-called impalpable testis.
Then you have to go hunting. And laparoscopy keyhole surgery is the gold standard here. You put a camera into the abdomen. If you look inside and you see the testis way up high, near the kidney or the internal ring, you got a problem. The blood vessels, the testicular artery and veins, they might be too short to just stretch all the way down to the scrotum.
And if you pull too hard, you're just going to snap the blood supply or cause it to spasm and block off?
Exactly.
Yeah.
You'll bring down a dead testicle, which is pointless.
Yeah.
And that's where the Fowler-Stevens procedure comes in. It's a really brilliant bit of surgical strategy. It's mentioned in the text. It's often done in 2 stages.
Okay, walk us through that.
So in stage 1, you go in with a laparoscope and you actually clip the main testicular vessels. You deliberately cut off the main blood supply.
Wait, hold on. You cut the main blood supply to save the organ? That sounds completely backwards.
It does, doesn't it? But you leave the testes right where it is. You don't try to move it yet. By clipping that main supply, you force the body to rely on its backup generator. The testes starts to draw all its blood from the tiny artery of the vas deferens and the cremasteric vessels. Over the next 6 months, these collateral or backup vessels get bigger and stronger.
So you're intentionally rerouting the traffic, building up the side roads.
Precisely. Then, 6 months later, you do stage 2. You can now mobilize the testes on this wide pedicle of collateral vessels, which have plenty of slack, and bring it down safely to the scrotum. It's playing the long game to save the organ.
That is fascinating. Just brilliant physiology. Okay, let's do a quick check-in for our listeners to make sure this is all sticking.
Right. Think about that timeline we just discussed.
Check-in, question 1. Your GP, you see a 6-month-old boy with a unilateral undescended testes. His parents ask if they should just wait and see for another year because they heard their uncle had the same thing and he turned out fine. What do you tell them? Pause and think for a second.
The answer has to be a firm no. By 6 months of age, spontaneous descent is highly, highly unlikely. You should be referring them to a pediatric surgeon immediately to plan for an orchidopexy, ideally before that child turns 12 to 18 months old. Waiting any longer is just allowing permanent fertility damage to occur. If you didn't get that right, maybe rewind and listen to that section on heat damage again.
All right, let's move on. Part 2, the ticking clock. We mentioned it right at the start. Time is testicle. We were talking, of course, about testicular torsion.
This is the one diagnosis you absolutely cannot afford to miss. Torsion is a true, time-critical surgical emergency.
So, anatomically, why does this happen? Most of our organs don't just randomly twist around their own blood supply. My kidney doesn't just decide to spin around.
No, because your kidney is retroperitoneal. It's fixed in place. And the testis is also meant to be anchored. Normally, the tunica vaginalis, that little sac that surrounds the testes, is attached to the posterior wall of the scrotum. But in some males, there's a congenital anomaly called the bell clapper deformity.
That's a great name. What does it mean?
Well, just imagine a bell. The clapper inside hangs completely freely. It can swing in any direction. In this deformity, the tunica vaginalis attaches way too high up on the spermatic cord, so the testes just flows freely inside that sac, exactly like a clapper in a bell.
So it's just dangling there on its cord with no anchor at the bottom to stop it from spinning.
Correct. And that cord, of course, contains the testicular artery. If the testes spins, it kinks the hose, blood can't get in, and maybe more importantly, venous blood can't get out, which leads to massive congestion and then very quickly ischemia and death of the tissue.
What triggers the spin? Is it always, a direct kick to the groin in a soccer match?
It can't be trauma,
Yeah.
but often it's terrifyingly spontaneous. It can happen during sleep. We think it's related to the cremaster muscle contracting, maybe because of a cold draft, a bad dream, even sexual arousal. It just spins the testes. And it's most common in adolescents, that sort of 10 to 25-year-old age group.
Okay, let's go back to that 14-year-old boy from the intro. We know the stakes are high. What does he look like when he comes in? What are the classic signs?
Sudden, really severe pain. It's often felt in the groin or can even be referred up to the lower abdomen, which is why it can mimic appendicitis. Vomiting is a very, very common symptom. The visceral pain reflex is incredibly strong. On examination, the testes will be exquisitely tender. It might be swollen, but the key sign to look for is its position.
The high-riding testes.
Yes. Because the cord is twisted on itself, it physically shortens and it sort of reels the testes up towards the groin. And if you try to stroke the inner thigh to get that kermasteric reflex we talked about earlier,
It's gone.
it's absent. The muscle's already in spasm or the whole mechanism is just jammed up.
Okay, here's a scenario I see in medical dramas all the time, and I know it happens in real life. The doctor is 90% sure it's torsion, but they order a Doppler ultrasound to confirm the blood flow before they call the surgeons. Is that the right move?
This is a major point of contention. But Baily and Love, and pretty much every urological association in the world, is crystal clear on this. If your clinical suspicion is high, do not wait for an ultrasound. An ultrasound is a great tool, but it takes time. You have to book it, you have to transport the patient, wait for the radiologist to report it, and they can have false negatives. You might see some flow, which is actually just inflammation around an already dead testis.
So relying on the scan just wastes time that you absolutely don't have.
Exactly. If you are within that critical 6-hour window, you go straight to the operating room. The surgical exploration is the diagnostic test. If you open up the scrotum and it turns out it's not torsion, fine, you close it up, no real harm done. But if you wait for a scan and you miss that window, you've lost the organ, period.
Why is that 6-hour number so specific?
It's all based on ischemia data. If you manage to untwist it within 6 hours, the salvage rate is nearly 100%. If you wait 12 hours, it drops to 50%. And in 24 hours, it's below 20%. The tissue necrosis just sets in so fast.
So you operate. You open the scrotum, you deliver the testes, you untwist the cord, and hopefully you see the color return. It pinks up, as they say. But you don't just close the skin after that, do you?
No, absolutely not. First, you have to perform a fixation. You use non-absorbable sutures to stitch the testes to the scrotal wall at 3 points. You are creating that anchor that nature forgot to put in. And this is arguably the most critical part of the entire operation. You must explore and fix the other side, too.
The healthy side, why?
Absolutely. Because the bell clapper deformity is a congenital anatomical defect. It's a problem with how he was built. If he has it on the right side, he almost certainly has it on the left side. You don't fix the other side, you're just sending him home to potentially lose that one next week or next year. It's a mandatory preventative strike.
Before we leave torsion, are there any lookalikes? Things that can mimic it but aren't quite as dangerous?
Yes, the main one is something called torsion of a testicular appendage, specifically the hydated of Morgagni. This is a tiny vestigial remnant like a little teardrop of tissue that sits on the top of the testis. And it can twist on its own little stalk. It hurts a lot, but it's not catastrophic because the main blood supply to the testes itself is completely fine.
And is there a trick to spotting that without having to cut the patient open?
Sometimes. You can sometimes see what's called the blue dot sign because the skin of the scrotum is so thin that tiny necrotic black and blue appendage can actually shine through as a little blue spot at the upper pole of the testes. If you see that and the main body of the testes feels okay and isn't high riding, you can often manage it conservatively with pain relief. But again, if there's any doubt at all.
When in doubt, explore.
Always. Every single time.
All right, let's move on to part 3, plumbing problems. We're talking about lumps, bumps, and fluid. Let's start with the varicocele.
A varicocele is essentially varicose veins of the scrotum. The pampiniform plexus, which is the network of veins that drain the testes, it becomes dilated, tortuous, and incompetent.
The classic description you always read is a bag of worms.
And it really does feel like that. It's a kind of squishy, irregular mass that's usually found above the testes. And here is a fascinating anatomical fact that comes up on every single surgical board exam. 90% of varicoceles occur on the left side.
Okay, why the left? Is nature just biased against the left side?
It's pure plumbing dynamics.
Yeah.
The right testicular vein has a pretty easy life. It drains directly into the massive inferior vena cava at a nice, gentle, oblique angle. There's a smooth merge onto the highway. The left testicular vein, on the other hand, has to travel all the way up and drain into the left renal vein. And it joins at a sharp, perpendicular 90-degree angle.
So it's like a T-junction on a highway instead of a slip road.
Exactly. It creates more turbulence and higher hydrostatic pressure. Plus, on top of that, there's something called the nutcracker effect. The left renal vein itself passes between two huge arteries, the aorta and the superior mesenteric artery. So it can actually get squeezed between them, which creates back pressure all the way down the testicular vein.
Wow. Okay, so this leads to a massive clinical red flag then. If 90% are on the left for anatomical reasons, what does it mean if you find an isolated varicocele on the right?
That is a huge danger signal. If you find a new right-sided varicocele in a man who's never had one before, you must assume something is blocking that vein from the outside. You have to worry about a retroperitoneal tumor, specifically a renal cell carcinoma, a kidney cancer, that's growing into the renal vein and physically obstructing the flow.
Wow, so a lump in the scrotum could actually be the first sign of a kidney cancer.
Correct. You must always image the abdomen if you find a new onset isolated right-sided varicocele.
And does the varicocele matter for the testis itself, aside from being a sign of something else?
It does. It's the most common correctable cause of male infertility. All that stagnant, warm blood pooling around the testes acts like a radiator. It raises the local temperature. And remember, the testes hates heat. So by fixing the varicocele, either with surgery or embolization, you can often improve sperm counts and quality.
Okay, let's switch from veins to water. Hydrocele.
Yep, hydro meaning water. It's simply a collection of serous fluid that builds up between the parietal and visceral layers of the tunica vaginalis. The testes is essentially just floating inside a water balloon.
And the key diagnostic test here is pretty low-tech, the flashlight test.
Transillumination. It's a great bedside test. If you shine a strong light through the scrotum from behind, a simple hydrocele will light up brilliantly, like a Chinese lantern. It glows red. A solid tumor or a hernia, on the other hand, usually won't let light pass through because they're full of dense tissue or bowel.
Now, Baily and Love talks about 2 different surgical approaches for this, a Lourdes procedure and a Jabelet's procedure. Why do we need 2 different operations?
It all depends on the sac itself. The problem with a hydrocele isn't the fluid, it's the sac that keeps producing it. If you just stick a needle in and drain it, it'll fill right back up in a week or 2. You have to disable the sac.
Okay.
So the Lourdes operation is for thin-walled, flimsy sacs. You basically plicate the sac, you gather it and stitch it up in bunches like a concertina or ruffled curtain. This stiffens it and crumples it so it can't collect fluid anymore. The Gibuli's procedure is for big, thick-walled, chronic hydroceles. You can't bunch those up. So for those, you actually invert the sac, you turn it completely inside out, and tuck it behind the testes.
It's amazing how mechanical surgery can be. Just stitch it up or flip it inside out. Okay, time for another check-in.
Let's do it.
Check-in question 2. You are examining a 50-year-old man. You find a bag of worms swelling on the right side of his scrotum. He says he just noticed it a few weeks ago. He has no pain. What is your next move, and more importantly, why?
You should immediately order an abdominal CT scan, or at least an ultrasound. An isolated new-onset right-sided varicocele is a major red flag for a retroperitoneal mass, most likely a renal tumor that's obstructing the venous drainage. Do not just reassure him and send him home with supportive underwear.
Right. Moving on to part 4, inflammation and infection. Epididymal orchitis.
So this is inflammation, usually infection, of the epididymis and the testis itself. It presents with a swollen, painful red scrotum.
Which sounds almost exactly like torsion. How on earth do you tell them apart?
It can be really difficult, honestly. But usually an infection has a more gradual onset. It develops over days, not in an instant. There might be a fever, and often there are symptoms of a urinary tract infection, like burning when peeing, which we call dysuria. Also, there's a clinical sign called Preen's sign. If you physically elevate the scrotum, just supporting the weight of the testicles with your hand, the pain is usually relieved in infection because you're taking the drag off that inflamed cord. In torsion, moving the testes at all usually makes the pain worse or does nothing. But you have to be careful. It's not 100% reliable.
And if you stick an ultrasound probe on it, what do you see?
That's the definitive test. In infection, you see increased blood flow, what we call hyperanemia, because of all the inflammation. In torsion, you see no flow, or very little. That's the key difference.
Okay, now there's an age divide rule for treating this, right? The bug depends on the patient's birthday.
Correct. And this is really important because it dictates your choice of antibiotic. If the man is under the age of 35, you have to assume the cause is a sexually transmitted infection, usually chlamydia or gonorrhea. If the man is over the age of 35, it's usually caused by typical urinary or gut bacteria E. coli, Klebsiella. And this is often secondary to something like an enlarged prostate causing urine retention, or maybe a recent catheterization.
So under 35, you're treating for STIs, something like ceftriaxone and doxycycline. Over 35, you're treating for a UTI with something like ciprofloxacin.
Broadly speaking, yes. Though obviously taking a good sexual history is more accurate than just looking at their ID card.
I want to quickly touch on 2 specific infections mentioned in the text, mumps and TB. Mumps feels like a bit of an old-world disease now.
It is much rarer now, thanks to the MMR vaccine, but mumps orchitis is nasty. It's a viral infection that usually happens in postpubertal males who get mumps. It causes massive painful swelling. The real danger is that the swelling happens inside the tough, fibrous capsule of the testes, the tunica albuginea.
Right.
So pressure builds up, it can't escape, and it kills the tissue inside. This leads to testicular atrophy. The testes just shrinks and dies off, which can cause infertility.
And what about tuberculosis?
TB has a real predilection for the epididymis. It creates a classic physical sign that Baily and Love describes as a craggy epididymis. It feels firm, irregular, and very hard. And if you feel the vas deferens, it can feel beaded, like you're feeling beads on a rosary necklace. It's often secondary to renal TB, so if you find a craggy epididymis, you have to check the kidneys.
Craggy and beaded. Those are great descriptive words to remember for an exam. Okay, part 5, the lump. This is the one every man fears. Testicular tumors.
And with good reason. Testicular cancer is the most common solid tumor in young men. That's the key demographic. Men in their 20s to 40s. It strikes men right in their prime.
And what is the golden rule here? The one thing you must never forget.
Any solid testicular lump is cancer until proven otherwise. Period.
Oh.
If you feel a hard lump that is in the body of the testes, not separate from it like a cyst would be, you must assume it's malignant.
And the mandatory next step, the investigation is?
Ultrasound. It confirms whether the lump is solid or cystic, and it characterizes it.
Let's break down the types. The chapter splits them into 2 main camps, seminoma and non-seminoma.
That's the most important divide. So seminomas arise from the sperm-producing germ cells. They tend to happen in a slightly older group men in their 30s and 40s. They're usually slow-growing, homogeneous on ultrasound. And the really good news is they are extremely sensitive to radiotherapy and chemotherapy. NSGCTs, which are Non-seminomatous germ cell tumors tend to be in younger men, 20s and 30s. And these are a real cocktail of different cell types. Teratoma, embryonal carcinoma, yolk sac tumor, choriocarcinoma. They tend to be more aggressive and spread earlier.
And we have blood tests for these, right? The tumor markers?
Yes, the fingerprints of the tumor. There are three you absolutely need to know. Number one is AFP, or alpha-fetoprotein. This is the key differentiator. AFP is never raised in a pure seminoma. If the AFP is high, it is a non-seminoma by definition.
Got it.
Number two is HCG. This can be raised in both types, but very, very high levels might suggest a choriocarcinoma component. And number three is LDH, which just measures cell turnover and tumor burden. It tells you how much cancer is there, but not what type it is.
So high AFP equals non-seminoma. That's a great anchor. Now let's talk about how it spreads. This is a massive trap for students. If I have an infection in my foot, the lymph nodes in my groin swell up. If I have cancer in my testis, do my groin nodes swell?
No, and this is so important. If you just check the groin for nodes and don't find any, you might falsely reassure yourselves and the patient. You have to remember the road trip. The testes started its life up in the abdomen, so its lymphatic drainage goes back to where it came from. The metastases go to the para-aortic lymph nodes way up in the back of the abdomen near the renal arteries.
So you could have a massive testicular tumor with advanced spread and still have zero palpable lumps in the groin.
Exactly. You would see the nodes on a CT scan of the abdomen, or maybe even on a chest x-ray, as cannonball metastases, if it's really advanced. The only time it goes to the inguinal or groin nodes is if the tumor has physically invaded through to the scrotal skin, or if the patient has had previous scrotal surgery that has messed up the normal drainage pathways.
That is such a critical distinction. Okay, so you've diagnosed it on ultrasound. You assume it's cancer. What's the surgery? Do you just biopsy it first to be sure?
Never, ever biopsy a testicular tumor through the scrotum. I cannot stress this enough. If you stick a needle through the scrotum into the tumor, you risk seeding cancer cells into the scrotal skin. You completely change the lymphatic drainage from the abdomen to the groin, which makes a curative treatment much more complex and morbid.
So it's shoot first, ask questions later, basically.
You perform a radical inguinal orchidectomy. You make an incision in the groin, just like for a hernia repair, not on the scrotum. You find the spermatic cord, you clamp it high up at the internal ring to stop any cells from shedding into the bloodstream, and then you remove the entire testes and cord en bloc. Then, and only then, do you send it to the pathologist for the final diagnosis.
It sounds aggressive, but the cure rates these days are amazing, aren't they?
They are one of modern medicine's greatest success stories. Before the 1970s and the introduction of platinum-based chemotherapy, specifically a drug called cisplatin metastatic testicular cancer, was effectively a death sentence. Now, the cure rates are over 90%, even with metastatic disease. Lance Armstrong is the famous example. He had metastases to his brain and lungs, and he survived.
It really is incredible progress. Okay, we're in the home stretch now. Part 6, the really acute stuff, emergencies and trauma. Let's talk about the absolute nightmare that is Fournier's gangrene.
This is a condition that if you see it once, you will never, ever forget it. It is, simply put, necrotizing fasciitis of the perineum. It's a flesh-eating bacteria that attacks the scrotum and the perineal area.
Who gets this? Is it random?
No, it's usually in patients who are immunocompromised in some way. Diabetics, severe alcoholics, people on immunosuppressants. It often starts from something that seems trivial. A tiny scratch, a perineal abscess, or a small leak from the urethra.
And it moves fast.
Terrifyingly fast.
Yeah.
You might see a little black spot on the scrotum, but the infection is already spread along the fascial planes, sometimes all the way up to the chest wall. The patient is septic, they're confused, they're very, very sick, and you can sometimes feel crepitus, which is this crackling sensation, like feeling bubble wrap under the skin. That's gas being produced by the bacteria.
What's the treatment for that?
You cannot just give antibiotics and hope for the best. This requires aggressive, radical, surgical debridement. You have to take the patient to the operating theater immediately and cut away all of the dead and dying tissue until you see healthy bleeding tissue. You essentially scalp the scrotum. It looks horrific, but it is absolutely life-saving. The mortality rate is still very high, around 20 to 40%, even with modern care.
That is truly sobering. A quick historical note that the chapter mentions scrotal cancer.
Yes, chimney sweeps cancer. This was described by Sir Percival Pott way back in 1775. He noticed that chimney sweeps in London, who were covered in soot all day, and that soot would collect in the rugae, the folds of the scrotum, had incredibly high rates of scrotal skin cancer. It was a landmark moment in medicine, the first time anyone ever linked an environmental chemical a carcinogen, directly to a specific cancer. It changed occupational health forever.
And finally, trauma. A kick to the groin, a baseball injury. It hurts like hell, but when do you actually need to operate?
Most blunt trauma, can be managed conservatively with ice, elevation, and rest. But you need an ultrasound. What you're looking for is the integrity of the tunica albuginea. That's the tough white capsule of the testes. If the ultrasound shows that the capsule is ruptured, then the toothpaste is out of the tube. The seminiferous tubules are exposed and will die.
Oh, you have to operate.
You have to operate to close that capsule. If you leave a ruptured testes, it will almost certainly atrophy and die. So the ultrasound is the referee there. It makes the call.
We have covered a massive amount of ground, from the car stalling on the highway to flesh-eating bacteria. So let's recap. If you had to give the listener the big 3 takeaways, the absolute must-not-forget points from this whole chapter, what would they be?
Okay, number 1, torsion is a race against time. You have about 6 hours. If your clinical suspicion is high, skip the ultrasound and go straight to surgery. And always fix both sides. Number 2, the solid lump rule. Any painless solid lump inside the testes is cancer until proven otherwise. Do not biopsy it through the scrotum. Remove it via a groin incision.
Mm-hmm.
And number 3, the 3-month window. For undescended tests, if they're not down on the scrotum by 3 months of age, they need a surgeon. Don't wait until they're school age, or you've already sacrificed their future fertility.
That's a fantastic summary. And to leave everyone with, here's a final provocative thought from the chapter that really stuck with me. The text mentions something called vanishing testis syndrome. You go in surgically looking for an undescended testes and you find nothing, just a little nubbin of scarred tissue.
Yes. The leading theory for that is that these boys suffered a testicular torsion in utero before they were even born. The testes twisted, it died, and it was simply reabsorbed by the body, leaving just a tiny ghost of itself behind.
It just makes you wonder, doesn't it, how many other absent organs are actually the ghosts of silent accidents that happened before we were even born?
It's a haunting thought for sure.
On that note, we are going to wrap up. We really strongly encourage you to grab Baily and Love's Short Practice of Surgery, find Chapter 86, look at the diagrams of the Fowler-Stevens procedure, memorize the tumor staging tables. We've given you the skeleton. The book really puts the flesh on the bones.
Keep learning, keep questioning, and always respect the anatomy.
Thanks for listening to The Deep Dive. We'll see you on the next one.